Why do so many doctors never mention brachytherapy? I'm Dr. Ajay Bhatnagar. I'm a radiation oncologist, and I've treated over 15,000 men with prostate cancer. There's something I say to almost every new patient I see, and it almost never gets said before they walk into my office. Brachytherapy stopped being offered because it stopped making money for the clinics that used to offer it. That's the whole answer. But understanding how it happened matters because once you see the mechanism, you'll know exactly what question to ask and who to ask it to. What used to happen in the 1990s into the early 2000s, LDR brachytherapy, which is a prostate seed implant, was common across the US. Radiation oncologists offered it alongside other treatments. Men got to choose. It was a real option on a real menu. Then the reimbursement rules changed with newer radiation treatments. Brachytherapy became the lowest revenue radiation option available. Clinics that had been running brachytherapy programs looked at the math and stopped investing in them. They didn't upgrade equipment in brachytherapy or recruit doctors who knew the technique. Nobody asked the doctors who already knew brachytherapy to train anyone coming up behind them. Here's why the training gap matters specifically. Brachytherapy requires something called an authorized user license for radioactive material. Only radiation oncologists can hold it. Urologists can't perform this procedure, no matter how experienced they are. When reimbursement dropped and clinics deprioritized brachytherapy, the radiation oncologists who knew the technique got older and retired. The next generation got trained in external beam radiation instead because that's what their programs offer. External beam radiation is delivered by a machine, a big one. Those machines cost millions of dollars. Cancer centers that bought them made a capital investment, and capital investments have to be used. A clinic that owns a $10 million machine has a structural financial reason to steer patients towards it. That's not a conspiracy, that's accounting. And then there's a second layer to this. Some urologists own stakes in radiation centers. When your urologist refers you to an external beam program at a facility they profit from, they have a financial reason to make that referral. They can't perform brachytherapy themselves, so they don't refer you to someone who can. Again, that's accounting, but it shapes what you hear. The result is a generation of men who walk into their first prostate cancer consultation and never hear brachytherapy mentioned at all. Their doctor's clinic stopped offering it years ago, often before that doctor was even trained. Doctors can only offer what their practice does. If brachytherapy does come up, it usually sounds like one of a few things. We don't do that here, with no clinical reason attached. Or that's old technology, which isn't a clinical judgment either. It's the natural output of a system that stopped investing in a technique. When fewer people perform a procedure every year, it starts to feel like it belongs to the past, even when the outcomes are still the best available. Two other things I hear from patients who brought it up on their own: we prefer more modern techniques, which is a way to dismiss a question without actually answering it. Or, I've seen better results with surgery. That's a volume bias. A surgeon who does 300 prostatectomies a year and 0 brachytherapy procedures has one frame of reference. It reflects their experience, not a data comparison. The data hasn't changed. For low and intermediate risk prostate cancer, LDR brachytherapy carries above a 98% cure rate. It's a 30-minute outpatient procedure with same-day discharge. Most men are back to normal activity the next day, and 76% keep their sexual function. Those numbers aren't from the 1990s. The outcomes are current from a procedure that's still the most effective radiation option for localized prostate cancer. The technology held, the financial incentive to offer it collapsed, and the omission doesn't only affect low-risk men. Take Michael. He was 68, newly retired, with high-risk prostate cancer. His first consultation told him he needed 2 2 years of hormone therapy plus external beam radiation with a best realistic cure rate of 65%. Impotence was likely. 2 years of hormone suppression side effects were certain. His odds still weren't great. What he didn't hear about was triple therapy, external beam plus brachytherapy plus 6 months of hormone therapy, not 2 years. Triple therapy carries a 92% cure rate. He got that combination through my practice. Within a year, he was back to his normal life. The gap between what he was told and what was available to him wasn't a clinical judgment. It was a referral pattern. If you want the full picture on prostate cancer treatment, not just what your clinic happens to offer, subscribe. Every week, I put out a video based on 20 years and 15,000 patients. I cover what most men never hear from their own doctor. I spent the first half of my career in a general radiation oncology practice. I did prostate brachytherapy on the side while watching it disappear from the field around me. I saw which patients weren't being offered it, and I saw what happened when men found out it existed after they already had surgery or finished a long course of external beam radiation. The surgery had already taken their urinary function or their erections. The external beam course had already run for 8 weeks. They were sitting across from me saying their own doctor never mentioned a 30-minute outpatient option with a higher cure rate. That's not a scenario you forget. I saw it enough times that it stopped feeling like a gap in patient education. It started feeling like a structural failure I had to do something about. In 2022, I left my practice in Arizona to build a practice dedicated exclusively to this procedure because the only way to fix this problem was to make the option available again. My practice is now expanding nationally because men are traveling to find a treatment their own doctor never mentioned. The omission reflects where you went for your consultation, not what's right for your case. Your doctor works inside a system that stopped offering brachytherapy. That's why it never made it onto the list. There is one question worth asking at your next consultation. Ask your doctor whether LDR brachytherapy is an option for your case and what the clinical reason is if it's not. That's not a confrontational question. It's a reasonable one. Any radiation oncologist who offers brachytherapy can answer in about 2 minutes. If you haven't gotten that consultation, you haven't seen the full picture yet. Brachytherapy has one technical requirement worth knowing about. Your prostate needs to be under 60 grams for the seed implant to be placed correctly. That's something a urologist measures as a part of a standard evaluation. If your prostate is under 60 grams and your cancer is low or intermediate risk, you qualify. And if you qualify, you deserve to know that before you do commit to anything else. High-risk cases, also like Michael's, can also be candidates for triple therapy. The risk level doesn't automatically take you off the table. You were overlooked because of the way the system runs, not because of your case. The omission isn't personal, but now that you know the mechanism behind it, you know what to do next. If you've ever wondered why brachytherapy seems to have disappeared from most cancer centers and what the outcome numbers actually show, watch this next. It's called After 15,000 Patients, I Changed What I Recommend for Prostate Cancer.